I'm Scott Shipman. I lead Creighton's Institute for Population Health. This is a seminar series in policy, health policy, that the Institute is doing in partnership with the School of Medicine. This is our second quarterly seminar speaker, so we're off to a great start. I want to thank the planning committee that helps us with identifying topics and speakers for the seminar series. We hope that you'll continue to come back for these over time. When the Institute for Population Health launched, which was now about 2.5 years ago, we had the great privilege of having Dr. Lindsay Huse as one of our keynotes, along with the mayor, to offer their perspectives on the value of population health and the role of population health in their work, which is perhaps pretty overt when you are the director of the Douglas County Health Department, as Dr. Huse is. Dr. Huse is a nurse practitioner by training and also has a master's in public health. She has been at the Douglas County Health Department now for almost 5 years, and I'm sure has many stories she can tell us around today's topic from her experiences there. She's an adjunct professor at UNMC, also at Metro Community College, and a real leader in the public health space, both regionally, of course, and in our state, but also nationally. As Lindsay comes up, I will just say our planning committee really was excited about the idea of talking about the challenge today of leading in public health in a very polarized political environment. The whole topic of trust in authority, in healthcare, in public health has come under incredible intense scrutiny and challenges that you don't have to be too observant of the national news to be aware of. So the idea of being able to focus a conversation, and I hope this will be a conversation. We do have a presentation, but we're leaving plenty of time for dialogue at the end about how we navigate the challenges that exist with a highly politicized environment that tends to be anti-public health, if I can be so bold as to say, in some overt respects, is the reality that any public health leader is having to offend today. And so I was so thankful that Dr. Huse accepted our invitation on what can be a pretty tough topic to talk about, I expect, but I think she'll navigate it exceedingly well. So Lindsay, we'll hand it over to you.
Okay, well, first of all, thank you for the invitation to come speak today. I am actually really excited to get to talk to you about policy and public health and politics and vaccines and all that fun stuff. I was apologizing in advance before my mic wasn't working so well. I get a little bit dry at times, so if I have to stop and take a sip or clear my throat, I apologize. But we will just jump straight in. So as always, conflict of interest disclaimer. We partner quite a darn bit with Creighton. We have contracts, but I have no financial conflict with this particular activity. And what I'm hoping that you will be able to walk out of the room with today is really a better understanding of what it looks like to engage around these hard topics, in this case, vaccines, and how policy influences the landscape in which we are trying to get vaccines into people, help you to identify some of the specific strategies that are actually used out there around vaccine mis and disinformation, because that actually influences a lot when it comes to policy, and maybe give you a few pointers on how you can actually combat some of that hesitancy or some of those tactics that you see, and then hopefully able to synthesize the principle of care for the whole person. So in public health, we like to think about the whole person. In fact, not just the whole person, but the systems in which those people operate and live and work and play. And so really thinking about What does it look like? It's something very simple, but actually can be pretty hard, especially when you have very diverse political ideologies, maybe even moral ideologies. And so, how do you look at the whole person and help move that needle in terms of public policy? So I'm a little bit of a history nerd, and I always feel like you need a little bit of history to understand the context of where you are now. And so I did a little bit of a dive back to see kind of what public health policy and politics around vaccine looked like back in the day. And I don't know if there are any Battlestar Galactica people out there. I'm going to guess just based on, oh, thank you. There's one. Yes. Okay, so it's a sci-fi show. It got a reboot in around 2005. It's fantastic.
Me too.
Woohoo!
Me too.
Yes. So I know sci-fi more than anything else, and so that's where all my silly anecdotes come from. But there is a quote in this series that is so salient to this conversation that we're having here today, and that is, all of this has happened before, and all of this will happen again. And I think that that theme is going to become pretty clear to you, but we have been encountering issues around policy and the pushback politically around vaccines, literally since the very first vaccine. So way back in the 1800s, Edward Jenner basically figured out that if you inoculated somebody with the pus from one of these little lesions, you could actually boost their immune system to recognize it so that they wouldn't get an infection. So that was, I mean, the very birth of one of what has been one of public health's most successful campaigns and interventions ever. And so pretty big deal. But even then, almost immediately, there was pushback from a sanitary standpoint. And to be honest, I mean, I kind of get it. If you're, collecting the fluid from somebody's smallpox vaccine lesion and putting it into somebody else, it's kind of gross. We do it way better now. But there were sanitary issues that people pushed back on. Even back then, there were religious issues or religious concerns that people had. There were scientific concerns. So science wasn't quite what it is now in terms of being methodical and structured in quite the same way. And so not everybody felt like that was something that maybe was scientifically sound. And then there were political objections, even that far back. And part of that is that when it was discovered that this was an effective way to fight infections and to keep them from spreading and kind of decimating these communities, there were laws starting to pop up in communities and states, basically requiring people to have these in order for the kids to go to school, or even to operate in some different industries where, perhaps you were in close quarters and could spread something like smallpox really easily. You can imagine how quickly that would take out your workforce. And so it would be in your best interests maybe to require people to have that. So 1879, the Anti-Vaccination Society of America was functioning well. I will say the United States and England both had very strong anti-vaccination groups that stood up almost immediately and were very, very active. There were actually court cases in numerous states that these societies actually would go to the hearings and push back against policies for vaccinations. So it sounds kind of familiar because we see some of these same things happening here in 2025, which we'll get to talking about here in just a little bit. 1902, this was a huge case for public health. So this was Jacobson versus Massachusetts. Jacobson refused mandatory vaccination. The city of Cambridge actually sued him for refusal. And he appealed that to the Supreme Court, and the Supreme Court actually upheld the city's right to require vaccination to protect the public. And that is an extremely important law or ruling when it comes to public health law, because that is precedent for a lot of the authority that we're able to use even today. And then by 1905, like I said, lots of schools and industries were actually requiring these. People were starting to carry around their little vaccine cards. Do you remember during COVID, we had the little vaccine cards that you had to like carry and show? Totally did that in 1905. Smallpox, if you're not familiar, if you get the vaccination, it actually leaves a pretty decent little scar. And so that actually also served as your proof of immunization. And so you could show that as proof if you didn't have your card. So sounds really, really familiar, doesn't it? It sounds like a lot of the same things that we're talking about in our environment today. I will say that while the 1800s were a little tough, we did have a little bit of a golden age in terms of support around vaccination. So polio outbreaks, definitely not a golden age, but there was wide support for polio vaccine. So it was pretty severe. Just in 1952 alone, 3,000 people in the United States died from polio, and that was just in a single outbreak. In 1955, Jonas Salk was able to get his innovative polio vaccine licensed. This was such a big deal. So a lot of people have seen the pictures of people, you know, little kids in the iron lungs. You may even have a family member who had polio, who perhaps have a disability that they've dealt with their entire life from polio. People were dealing with some pretty serious outcomes from this. And 1.5 million children were enrolled in the safety trials the year before this was licensed. That's a huge testament to how desperate parents were to make sure that their kids were getting this vaccination. And so I would say that of all of the vaccines that are out there, the polio vaccine is the one that's probably still the best supported from a political and a policy standpoint. Pretty amazing statistics when you look at what happened when we started getting the polio vaccine into people. You saw in the United States, 58,000 cases a year drop to 5,600. And then by 1961, that had dropped again to just 161 cases. That is incredible. Very, very effective vaccine that is still in use today. One of the really cool things about Salk that I wanted to throw out there is that he was really committed to equitable access. And access to vaccines is something that we deal with in the policy environment and politics still today. Surprise, surprise. But he really understood that in order for communities to be healthy, he couldn't hold on to that license and insist that he get paid big bucks for that. So he literally made no profit off of the license of that vaccine, which resulted in about 6 different manufacturers that were able to make that vaccine and get it out, not just to people in the United States, but globally. In 2021, there were only 2 wild polio virus cases in the entire world. We were also in the middle of COVID. That could have influenced some of it, but only 2 cases. So think of 3,000 people dying annually, 58,000 cases just in the United States, and then dropping to only 2 cases worldwide. That has gone up just a little bit since 2021. So last year, there were 94 wild polio cases. And when I say wild polio cases, that just means that those are polio infections that were transmitted from person to person, and it is its own variant, if you will, of illness. There is also a vaccine variant that you can have limited transmission with, but we can actually separate and tell, okay, this was a wild case, this was something that came from vaccine. And those cases were in Pakistan, Algeria, and Nigeria. I will say there is an amazing documentary out there about healthcare workers, I want to say in Afghanistan or Pakistan. Basically, what they go through day to day to get polio vaccine out to the people who live in their communities. It's considered illegal to be out giving that vaccine. So, I mean, they have snipers on the roof. Some of those workers have actually been shot. It's pretty incredible. And of course, I'm going to blank on what it's called. I'm going to look that up and let you know because it's really good. You should watch it. All right. So the controversies continue. Polio was kind of our breath of fresh air, if you will. Not as much pushback on that vaccine. But in the 1970s, the DTP controversy occurred. So this was something that started out in England. So there were about 50 kiddos over about 11 years that were diagnosed with encephalopathy after getting their DTP vaccine. And for those who don't know, DTP is diphtheria, tetanus, and pertussis. And it's given all as one shot, so all three of those components in one vaccine. And the thought was that the pertussis component was the part that was causing some issues with potentially this goodness sakes, guys, it's late in the day, would develop. And so they actually started the National Childhood Encephalopathy, I did it, guys, study. And they studied thousands of children that were essentially admitted for encephalopathy to see what kinds of exposures they've had. This is a very common kind of study that you would see in epidemiology in public health. And what they found is that it was very low risk. So basically, it was debunked, if you will. During that time, though, what we saw is that because there was this controversy and people didn't really know what was causing this illness, there were some countries who, out of an abundance of caution, suspended their DTP campaigns. And what you saw when that happened is that your pertussis cases increased 100 times in comparison to the countries that continue to give their vaccines as they had recommended previously. So I will say that even today, we see pushback with that pertussis component. We have people who still decline the pertussis vaccine. You can get it separate. You don't have to get it as this trivalent vaccine. You can actually separate that out. And now we have pertussis outbreaks. So you're going to hear about those from time to time in the community. 1998, a lot of people are really familiar with this one. So this was the MMR controversy, and this one does not seem to want to die, even though there have been thousands of studies that have been reviewed in meta-analysis and really have proven that this issue does not exist. And essentially, this was a doctor named Andrew Wakefield who published in The Lancet that MMR was potentially the cause of autism and some bowel diseases in children. And interestingly, his initial theory was that it caused bowel disease, not so much the autism part, but then there was an autistic patient in his huge sample size of like, I don't know, 5 people. It was very, very small. And so that kind of got his mind going on that track, and it got lumped in as well. Chaos ensued. There were lots of people who were, insistent that the MMR absolutely causes autism. This is something we shouldn't be giving our children. You still hear that every single day. Even though the Lancet retracted that study after it was found that the study was very poorly done and there were some ethical issues around that, including that the study was commissioned by a lawyer who was seeking to sue vaccine manufacturers. And so there was a vested interest to find an issue with that vaccine. And so conflict of interest is something that we take very, very, very seriously. And this unfortunately occurred and was not put out publicly to the extent that it needed to be. And it was found out later that led partly to that retraction. And they even, when they announced their results, actually had a big televised press conference. There was a lot of hoopla around it, basically saying that the vaccine was not something that we should be giving our kids, especially in the trivalent or the MMR formulation. I think everybody is familiar with this part. So COVID really was a new era in a lot of ways in terms of how we do vaccines in the world. Part of that is the speed with which we were able to identify the virus and then develop a vaccine. So the mRNA technology has been in use for a very, very long time for other medical applications. This was something that was being tried out, but all vaccine research takes time. So there are multiple steps that you have to go through to get a vaccine developed, tested, and trialed. And what happened is that they were able to kind of throw a lot of money at it, have manufacturers really stop production of other things, focus solely on the COVID-19 vaccine, and they were able to run some of their studies in tandem. So instead of just having one long line that stretched that timeline out, they were able to do some things side by side, which is awesome. It's unheard of to see a vaccine go from identification to production to in arms in under a year. That's incredible. And I think Operation Warp Speed was very apt. I'm sorry. The mic doesn't like the talk about the Operation Warp Speed. So interestingly, there wasn't a lot of transparency around how the vaccine was being made. And so there were a lot of misconceptions out there about whether those safety trials had adequately been done. And so almost instantly there was concern around, well, have they skipped steps? Has it been adequately tested? We still hear about that even today. And we had this little thing called social media that was not around to the same extent that it was, say, back when Andrew Wakefield was publishing his study. The internet was around. Certainly, you could learn things faster then. Nothing like we started to see with social media and just the speed with which not only information passed, but also mis and disinformation, lots of conspiracies. There was, at one point, if you remember, a time when they briefly paused administration of the COVID-19 vaccine. And that is because they were watching the data around safety in the population. So this was after it rolled out. And there was a potential concern around some cardiac events that they had picked up on. And out of an abundance of caution, they paused. They had their scientists look at all of the data. They did find a small, low risk, mostly for young men around that vaccine. And so what's awesome about that is that the system works. Unfortunately, people don't remember the part where that's how the system is supposed to work. It's supposed to, VAERS, if you don't know, if you don't have a lot of familiarity, I'll explain it here in just a little bit, but we're supposed to have kind of a wide net out there so that we can catch those safety signals and hopefully respond very quickly. And in this case, it worked great, but what happened is that people heard it causes these cardiac issues, it's not safe. You shouldn't take the vaccine. The COVID vaccine was also heavily politicized, really started kind of the mask mandates. I feel like I can talk for a while on that, but I won't. You know, some of these interventions that we put into place to help protect the public became highly politicized, and it almost became part of your political identity that you voted a certain way and you didn't get the jab, which we still hear that language quite a bit as well. We also learned some things around transparency, around how science actually works and how it takes time. We learn as we go, which means sometimes we have to change our recommendations. There were just a lot of different things that kind of came together. And I'm giving you all of this context because when we start talking about how people deal with mis and disinformation, it becomes really, really important. This is current. This is what's happening. And I hope that this slide feels really chaotic to you because that's exactly how it feels right now. So a lot has happened in the last year with RFK Jr. becoming the HHS secretary last February. We've had a whole host of changes, not necessarily driven by medical science, toward our vaccine schedules for children and adults, which is really, really scary for those of us in public health and really means that we have a lot of work to do. So they kind of flipped the script, if you will. So it used to be that certain more progressive or liberal groups were the ones who, oh, we don't vaccinate, we don't put anything artificial in our bodies, we're, you know, very close to earth and natural. And now it's flipped, and you see that there is less support on conservative sides for vaccination. I am happy to report that Nebraska, we currently are about halfway through our legislative session, and we really did suspect that we were going to have some policies around vaccine mandates, and we did not have any introduced, and we were kind of shocked. I don't know that that will hold, so it's a short session, so you have fewer, well, you still have a lot of bills that are introduced, but I suspect that there are some people out there who are waiting for a longer session to introduce some of that legislation. But so far, so good. But 10 other states right now have bills in process to essentially either lessen the mandates for vaccination. And when we talk about mandates, this is kids going to school and having to have vaccines for the most part. They call them medical mandates, but really this is focused mostly on vaccination. So you can see the states up there where things are going really well in some of them, and some there's no, like New York, it's not going to go through. It's not going to happen in New York. But other places like Idaho and Iowa, it very well could, and Iowa is right next door. I also wanted to just mention that vaccine-specific policy is not the only kind of policy that is going to potentially impact access to vaccines. We saw broad changes to our Medicaid payment system. That is something still being talked about at the federal and state levels. And if you don't have insurance, it's really, really hard to get vaccines. They're very expensive. There are some programs out there that we can utilize to help kiddos, and very limited for adults, get some vaccines, but by and large, your insurance is what's paying for these for most people. And so fewer people who are able to be on Medicaid means fewer people who can maybe get those vaccines. So where people like me step in is having conversations not just with legislators, but with constituents, people in my community, friends, family, to really start hopefully changing minds about vaccine. So this is what we've seen since the very beginning. You're seeing a tug of war, and there are so many different reasons for the tug of war. Sometimes it's around trust. Sometimes it's around, you know, access in those healthcare systems, or what people know or don't know about science. Culture and religion are huge ones for support or not around this. There's also very real historical trauma that has resulted in people not trusting vaccinations. There's personal experiences. So if you have a kiddo who 3 days after they got their MMR started exhibiting signs of autism, it's really, really hard not to make an association between that. And so as a parent, you're probably going to hold on to that pretty tightly, even if someone is putting science in front of you. And then algorithms, which is what I really want to talk to you about. Our algorithms are specially designed just for us. So if we are not supportive of vaccines, or really you could take vaccine out of this and insert just about any other public health intervention and it would work, okay? Your algorithms are built to continue feeding you information that you already agree with. It's feeding the bias that's already there. So if you have somebody who is vaccine hesitant, they're probably getting lots of vaccine hesitancy information in their social media feed. This contributes greatly to the spread of myths and disinformation. I don't know if any of you guys have ever tried to mess with your algorithm and on purpose go look for things that you don't agree with to see if you can start being fed some of that. It's really interesting, some of the things that you'll start seeing pop up. But there are a number of tactics out there, and the reason that I wanted to talk about this, because this influences how people build and react to policy. People are policy. Every policy we have is driven by humans. And so if you are being influenced day in and day out in a certain way, that is automatically going to influence policy at some level. So rhetorical tactics is something that we see a lot of. And by the way, there are more tactics out there than what I'm talking about today. But this is just kind of the highlight reel, if you will. So we have fake experts out there. So you might have somebody who has a PhD in biology or in botany, but because they can use the term doctor with a PhD, well, Dr. So-and-so says, don't put this stuff in your body. It's evil and bad. And so you can very easily find someone who has some credentials you can throw behind their name and have them say whatever is expedient. Logical fallacies is another issue. So highlighting vaccine schedules in another country would be an example of that. Like, well, of course we should change ours because Belgium does it differently. And look at how healthy they are. Impossible expectations is a huge one. So if somebody has let's say a minor side effect due to a vaccine, well, if you had a side effect, then it's dangerous. Your side effect could have been a localized rash or some redness, but they can take that and use that as, this is dangerous. Or if you say, well, you said that this vaccine is only 95% effective, that means 5% of people are still going to get sick. So what's the point? That's an impossible expectation. We also see people who cherry pick. So they are only giving you the information that is going to feed the bias or the basically what they want you to hear. Even if it's a discredited study, we still have people who point back to Andrew Wakefield. Conspiracy theories. I feel like there's a million out there. During COVID, it was that we were putting microchips into people. I gave a whole lot of those vaccines. I can tell you there were no microchips anywhere. Also, data suppression by a shadow government is one we hear all the time, that there's all of this data that says how dangerous vaccines are, but it's not making it out because the shadow government has been suppressing it. Emotional narratives are hugely effective. It's much, much more moving on a visceral level to hear a story about someone who experienced a bad outcome after getting a vaccine, rather than looking at some really dry, maybe boring data. And so that tends to move people. Moral framing, so when people are really framing their argument as, this is a liberty, our liberties are at stake here, versus, this is really medically safe, this is something that's helping your whole community. You can go both ways, but the moral framing is something that you'll see quite a bit. Toxin language, so what people like to use the chemical names because they sound really, really scary. And so, we can't be putting mercury in our bodies, through these vaccines, even though it's not the mercury that's necessarily heavily dangerous. It's very regulated, tiny, tiny amount, and I think they've now gotten rid of all of it. So lots of different tactics that are out there. Digital dissemination. So this was really interesting. So during COVID, they were actually able to trace about 65% of the misinformation around the COVID vaccine back to about 12 people. So it does not take very many people to get a campaign against a public health intervention going. So I was kind of shocked by that. There are also ways to hijack a person's algorithm just by adding a hashtag that looks like, you know, healthy living. I mean, who doesn't want to check out healthy living, right? And so now you have that information that's impacting people maybe who haven't really ever questioned an intervention before, and now they are. Echo chambers, we see these all the time. First of all, social media is an echo chamber. The algorithm is an echo chamber, but there are also groups that people can join where any dissenting view is basically anathema. It will get you kicked out. You can only say whatever the accepted view is. Technical data gets misused a lot, and VAERS is a prime example of this. This is that vaccine adverse event reporting system. It's that surveillance system that if somebody thinks that they've been harmed by a vaccine or they think there's been an adverse reaction from a vaccine, they can put that data in here. So it can say literally anything. If you get in a car accident 20 minutes after you got your flu shot, you could put that in there as a vaccine reaction. So obviously, not all that data is what people think it is, but they like to cherry pick out of there. And then you have the bots and the trolls, and you all know not to feed the trolls, right? Don't feed the trolls. So bots are more of a feature that spread bad content. Your trolls are the ones that like stir everybody up and get them mad. And I'm telling you all of these things because it is so important for you to be able to recognize them and also help other people recognize them. So when you have people who are advocating for certain policies and they're using bad information, it's so important that we're able in an effective way to point out where those issues exist. So they actually call it psychological inoculation. How salient is that? Because we inoculate people against diseases. I love that. Recognition of tactics decreases their stickiness. So just knowing that these are things that happen and being able to identify them as they're coming across your feed is extremely important. They've actually had people play games where they fed them bad news or wrong news. And the more they did that, the more immune they were to fake news in the real world, which is so cool. Pointing out the actual credentials of people, giving more context around, you know, things that have been cherry picked out of the data. And, you know, if people are trying to throw those fallacies out there, you can always try to draw them back to whatever the main point is that you're talking about. But really doing that, that inoculation where you're helping people identify, like this is not correct and here's why. We also want to do that early and often. So we want to pre-bunk more than we have to debunk because it's a lot easier to get people to accept what you're pre-bunking with than it is to get them to change their minds later. So important in public health, in all of public health, is to be first and be right when you're communicating to the public about things. And then, like I said, stopping that misinformation early is going to be much better. You can also use the sandwich method. Have you ever had the sandwich method when you've like gotten a job review or something like that? Like, this is going really, really well, and you're terrible at this, and this needs to be fixed, but we really love you. It's the same concept, but we're doing this with truth, lie, truth. So you state the truth, explain what the lie is that you're hearing, and then you restate the truth. Other ways that you can fight back, and this is really where the rubber meets the road, if you will. I spend a ton of my time in this particular space because calling, writing, emails, testifying, voting, all of those things still make a difference. It's easy to feel like you're one person and can't possibly be moving the needle, but I promise you it does. Legislators who have constituents calling them regularly about a topic are 11 to 12% more likely to actually support whatever that legislation is that people are asking them to support or to oppose it if that's the ask. And that is across party lines. It does not hold for one over another. It's everybody that is more likely. So it makes a difference the more of those phone calls and letters that they get. Providing expert testimony. If you have something that is like vaccine, if that is your bag, you know it so well, you're an expert, and there's legislation that you can testify about, you should absolutely testify. You can write letters of support, or you can actually show up in person on the day of a hearing to do testimony. This helps refine bills. So sometimes you're going to walk into like a committee meeting where they're on the first reading of a bill and it's terrible, like really badly written, because sometimes bill writers write these without all of the expertise that they need to do it effectively, or without all the context for how what they're asking for is going to actually impact the community. So if you go in there and are nice about it and help them work through where the issues are, sometimes you can develop some really nice collaborative relationships that are going to benefit your policy later. It also helps set agendas, and very importantly, it bridges the gap between science and action. So sometimes things sound really great in theory, and when you put something into action, it's not going to work as good as you think it is. And it takes a lot of people to make sure that you're aligning your science and your action well. And then voting, please vote. Please encourage everyone around you to vote. Help people vote. It makes a huge difference. There is actually a whole website that's devoted to comparing voter turnout to public health. And they find that states that have higher voter turnout actually tend to have stronger public health systems, which I think is pretty amazing. I want to point out the most important tool that you have when it comes to policy and politics, and that is you. You have something that social media doesn't have. The ability to actually make a human connection is incredibly important and absolutely can change a mind. If you are going into the healthcare field, you will be seen as somebody who has trusted expertise. And even if somebody doesn't agree with you the first time, the more you're able to compassionately and kindly show up in those conversations with them around that, eventually about 66% of people end up changing their mind. So that is a huge, huge difference when you're talking about some of these important public health policies. The key here, though, is that they have to feel heard first. So it's really tempting to want to go in and like preach to people about the importance of a certain public health intervention. It's more important that you first listen to any concerns or worries that the person in front of you has, and then respond compassionately with facts after that. If you do it the other way around, it will backfire. Patient-centered collaboration. So it's really just putting the person in the middle of your communication and how you're communicating. It's so, so important. In healthcare settings, we see that that decreases vaccine hesitancy and increases uptake when you're actually including people in the decisions and in the conversations around these interventions. Participatory approaches with parents especially, like I said, the first time, maybe even the second time or third time, they may not change their minds. But down the road, if you're proving that you're someone who is trustworthy and that you're willing to listen and to address concerns, that long-term trust has a huge, huge impact on really how people do support different policies. And then reflective listening and motivational interviewing techniques are huge. I don't know if anyone in here is familiar with motivational interviewing, but it's really a style to almost coach people through decision making in a way that puts that that thought process back on the person. So you're not doing the thinking for them. You're just kind of leading them through some critical thinking. And oftentimes, when we're able to do that well with people, you can get them to change their minds on on the policy. All of these things also work with legislators. So I have absolutely sat in a room with legislators who don't agree with something that I am hoping to get them to support. And being able to listen to their concerns first. This happened with Don Bacon. I will just throw that out there. Hopefully he's not listening. But, you know, was able to, it was a conversation about Medicaid. And I was able to listen to his concerns about the prices of long-term care and things like that. And if I hadn't listened to that first, I wouldn't have been able to have as good of a conversation with him around why that means that Medicaid and Medicare are so important to support, because those costs are going to be even more out of the world without those things available to people. And so it's just extremely important that no matter what you're talking about, whether that's vaccines or Medicaid or whatever, that you are approaching it with some humility, listening, and then responding with your facts, especially if you're getting some of that mis and disinformation back, some of those techniques. You'll know how to identify those and kind of mitigate that. So that is all I have for you today. I could have probably made this an entire like semester long class. There is so much information. So boiling it down to a 40-minute presentation is pretty tough. But if you have any questions, you want to continue the conversation, I will be here for a while. I think we have maybe some Q&A.
All right, let's open it right up for any questions or comments or thoughts from the audience here first, and we'll go online eventually as well. Let's start in the back. Oh, do I have a button I can push up here? Let's see. Table? Okay, it might work now.
Thank you so much for your presentation. I really appreciate it. My name is, and I'm a third year medical student and also a master's in public health student. With the idea of pre-bunking, how do you recommend we respond in emergency preparedness situations, such as with like the COVID pandemic? We don't have the correct information necessarily because we don't know it all yet. So how would you recommend in this type of situation in the future for emergency response where you don't necessarily have the information, but you still want to be able to provide the correct information sooner so that people hear it first?
You answered your own question and didn't even know it. You are transparent about what you know and what you don't know. If you show up in an emergency situation like you have every answer, people see through that. And if you're wrong, they're really going to see through it. So it's much better. And we do this all the time when we have a public health emergency. We don't have all the details up front. And so you just have to make sure that people know, I don't have every answer for you right now. Here is what I do know. And I am committed to, as we have more information, bringing that back to you. So as you show up in those spaces reliably and you're giving them the information that you have and you're being transparent about what you don't know, that actually builds trust. So, yep, you answered your very own question.
Yes, we're here.
Yes, you just mentioned emergency, and I know that there have been laws to say who gets to declare an emergency, and it's different in different places. Could you just address how you have had to deal with that?
Sure. So who gets to declare an emergency? It depends on the type of emergency. If it is a public health emergency, that isn't necessarily like a real thing at the local level, but we do it. We absolutely, usually it would be myself with the Board of Health that would basically put out a notification to the public through a press release or a press conference or whatever, a resolution on the board, basically saying this is the emergency that exists. And really it's an administrative tool to open up resources down the line. You will see it a lot more handled at the state level, or you'll see it come up at the state level where the governor can declare an emergency of some kind. Of course, the president is welcome to declare an emergency if he sees fit. But usually at the local level, when it's a public health emergency, which is very different than like a disaster emergency, we don't do that. That's all elected officials that do all of that. But a public health emergency is something that our Board of Health, which is an arm of our county board, would assist in doing. And I have gotten to do that a couple of times.
We have an online.
Yeah, we have an online question. It reads, you said it's important to be the first and to be right. How do you add nuance or the possibility for development or exist in a place where the answer may not be known?
Yeah, I think that really goes back to that first question that we had. Admitting what you don't know is so important. I can't stress that enough. Don't lie about what you know. Don't make it up. And I think that that is probably a lesson that we could have done a lot better with during COVID. I don't know that we were as transparent as we could have been around, hey, we don't know, and the situation is evolving, which means that our recommendations may change. We were just like throwing recommendations out there as things changed. And I don't know that we necessarily set the expectations very well. And so I think from the very get-go, again, here's what we do know. Here's what we don't know. Here's how we're monitoring this information or this situation. And we're going to get you the information that we can as soon as we can. And I think even saying this is a developing situation, which means as we learn more, some of this may change. And setting those expectations from the get-go, I think is something that is very effective. I've seen that tactic used in risk communication in multiple types of emergencies, and it's amazing how much calmer people in the community tend to stay and how much more trust in what they're hearing from officials can be if you do that.
When you were talking about trust with officials, obviously now there are competing vaccine schedules between nationally and organizations such as the AAP. How do you sort of like recommend managing conversations about that at like a personal level, but then also sort of like managing all of the ramifications of that at the system-wide level too?
I feel like that's $1 million question right now. I can tell you how we've decided to address that. So the schedule that has come out more recently from the CDC and kind of the changes to the ACIP committee, where a lot of expertise has been stripped out of that committee, and now we have kind of it's much more confusing, to be honest, the new vaccine schedule. We take the stance of, okay, yes, we support these, we support that these are, these 11 things, absolutely. But we also support the AAP, American Academy of Pediatrics, like whoever. We kind of walk the line between bridging both sets of recommendations. So the shared decision-making piece that has kind of been put into there is actually something that providers have been doing for decades already. And so we do at times say, we absolutely think you should have a conversation with your healthcare provider. In fact, call them right now, if you will, if that's what it takes to get you there. And it depends on where you are. In California, I would have a lot more, I would say, I would not feel as constrained by what I say as I do in a more, we'll say, purple environment in Omaha, where I don't want to alienate half of the people that I'm taking care of. So I'm responsible for everybody's health in the community. I have to consider everybody, whether I agree with them ideologically or not. And so I am very careful about kind of walking a line between, yeah, the CDC is putting this out. It's not, I mean, we still want you to follow these stronger things, but this isn't necessarily wrong. And so we do kind of walk that line. And there are other states where, in other communities, where you could not say AAP. You would only be allowed to talk about, supporting what the CDC has put out. State level communication differs a lot from local level. So I have more freedom in what I say than the state does. And so sometimes you'll hear a little bit different messaging come out, and it's because at the local level, we can be a little bit more, we can be cowboys, a little bit more at the local level.
That freedom, something that's in statute that you have that freedom, or is that just the current political environment in Nebraska allows you that freedom?
Yeah, I should say that it probably even depends on what kind of community that you're in. So if you're in an extremely conservative community, you might even have to think a little bit more about how you're putting out some of those recommendations. We are lucky in that we have pretty supportive, like, elected officials here, even ones that are perhaps on the more conservative side, who you maybe would think wouldn't be as supportive of, us telling the public that they should be doing something. We have a lot of support here, and we have a lot of collaboration across party lines here, which is a beautiful thing that not everybody has. So I would say heavily probably that, but also we have diverse funding sources, so I don't necessarily have to worry about, oh, if I say this, I don't have to think about that as much as something like the state.
Maybe one last question if someone has a burning question. Yes, Kevin.
You seem interested in history, and you told a nice overview of the history. And if things are cyclical, and we're at a time now where there's a lot of lack of trust of public health interventions, do you feel optimistic that would swing back, or do you think we have hit a very different point in history where it's unlikely to be recoverable?
That is a great question. I am an eternal optimist. So I will say that eventually I think that we'll probably see more trust in the system again. However, I think some bad things probably will be seen first. So I think that there is a component of the population that's going to have to experience things that we haven't seen because vaccines have been so darn effective. They may have to experience some loss and some hard things in their lives in order to realize that we truly were trying to help, and we truly were putting out good information, and that we were trustworthy. So I think I think that the pendulum eventually will swing back that way. I don't know exactly what that'll look like. Again, we have AI now and social media and like all of these crazy things that we didn't have 25 years ago when I started in public health. But I am optimistic. I think that we have a while to kind of suffer and go through some hard things. And we're going to try to minimize that as much as we can in public health, but I think we'll get there.
All right, well, so maybe some challenging times, but better times to come. As Dr. Huse said, we could continue to talk about this subject. Lots more questions that I have that I'm holding back. We do have the luxury of another hour of a reception. I think just outside here. Okay, just outside here. And Dr. Huse, I hope you're able to stay for that and to take additional questions. Let's have a round of applause for Dr. Huse.